Thank you for the invitation and opportunity to share my research on COVID-19. This is Yang from Department of Radiology at Biomedical Engineering and Imaging Institute. Today, my topic is artificial intelligence-enabled rapid diagnosis of COVID-19 patients. I have no financial to disclose. COVID-19, since its outbreak in early this year, has become a global pandemic. Currently, there are over 50 million cases globally, and in the United States, it's nearly 10 million cases. It's already a huge social burden, and the cases still increasing every day. So the virus for this COVID-19 is called SARS-CoV-2, and currently the golden standard to detect this virus is still reverse transcription polymerase chain reaction, in short, RT-PCR. So RT-PCR has very high sensitivity, but also the false negative rate is also very high. So that means if the patient is tested positive, very high chance is definitely positive. But if a negative, that doesn't always mean negative. Usually we need a series of tests to rule out a true negative. And results can take up to several days to complete, especially in the early this year. And of course, the shortage of supplies in outbreak regions. So since the disease is so contagious, it's very important to do some early and fast detections. As the imagers, the chest CT or chest array imaging might play a very critical role in diagnosis of this disease. So actually, our Sinai team has done some pioneer imaging work for this disease back to early February. Through some collaboration, we got some first-hand images in China and then start to analyze those. We published several papers to summarize the imaging features of this disease and also to investigate the relationship of the imaging findings to duration of the infections. We actually published a very, first several papers for these topics in the whole field. And as for the chest CT images, usually in the United States is not as a primary screening tool, and it's actually discouraged by the CDC. But in other countries like China, Russia, they're aggressive using the chest CT for screening purpose. There are some typical findings on the chest CT images, like ground glass opacity, usually bilateral, peripheral, and low lung distributions. Sometimes with very round, morphology, shown here, and also some airspace consolidation, reticulation, organization, and also crazy patterns shown here, and reverse hollow signs. There's also some atypical findings like peripheral effusions, cavitations, pulmonary nodules, etc. And as I mentioned, when we investigate the relationship to the duration of the infection with images, surprisingly we found in the early stage of the disease, for example, like within 2 days of exposed to the virus, actually from the chest CT images, over 50%, over half of that has very normal CTs. It will create a huge barrier for the radiologist to distinguish the COVID positive and negative with CT images at an early stage. Let's see some cases. The left one is a 33-year-old woman with 2 days fever and cough. And then you can see from the images, there's no very clear, there's no, image features as described before, like GGO, crazy pattern, none of that. And the right one is a 57-year-old man with abdomen for 3 days. You can clearly see some imaging features in the lower lung regions. Actually, both of these cases are positive cases. And here's another one, like 58-year-old woman with 4 days of generalized weakness, lightheadedness, and no fever. But we can see from images, there's a very typical imaging features. And definitely this is the case also RT-PCR positive. So what we can learn from the CT images, of course, the CT images have unique features which can be recognized by the radiologist. But we also need to acknowledge it. In early stage of this COVID-19, there are a lot of normal CTs. So when we think about how to combine this together, so using AI, so the AI's role in fighting this disease can be learning some features from imaging and transfer knowledge from the radiologist, and also deploy the model, the pre-trained models to instant get result after scan to reduce the reading time. Our solution for this one is try to using AI to combine both images with the clinical information to make rapid and also comprehensive diagnosis. This picture shows the overall like framework for our work. And as we mentioned, we have input, the both images and the long image information, including some exposure history, blood work, and basic informations. And we use some models for that. For images, we can see we are using some convolution neural net models to do some slide selection and then do some diagnosis. For the long image information, the clinical information, we are using standard machine learning models, SVM, random forest, MLP, etc. And then we're using the MLP to combine the imaging model and the clinical model together. So for output, you can imagine we have three outputs, like image only model outputs, like clinical information only outputs, and joint model outputs. As for the data, there are over 900 cases, around half the positive and negative RT-PCR results. And then we are using 60% of that for training, 10% for tuning, validation, and 30% for testing. As for all the test set was read by our two radiologists. One is very senior with multiple years of experience. One is a junior fellow to compare the performances with the models. Here's some more details about each modulator. For the image model, first step, we are doing the slide selection to select abnormality slices. And then this is based on our pre-trained TB model from the Inception ResNet V2. The general idea is based on from this one, we have some patient data and some control data. After this training, we will get some output for which slides might have a high chance for abnormalities. And then after that, we detect the abnormality slices. We will go through some ResNet 18 to first we will do the lung segmentation to segment lung regions, and then go through the ResNet 18 for further diagnosis. In the last layer, we use a max pooling layer to get some pixel-wise predictions, and then we average that to have a COVID-19 probability. For clinical information, we're using the fully connected layers, 3 fully connected layers, MLP models. Each layer have 64 units to predict the probability. Here's some information for the clinical information of the patients. So we are using the general information of sex, age, the temperature, and the exposure history, and some clinical symptoms including fever, cough, sputum. And for lab findings, we are using white blood cells, neutrophil and lymphocytes, and also a percentage of neutrophils and lymphocytes. Here's some key results of the models. As we can see, the joint model and the CM model and the MLP, and then compare with the radiologist from AUC curve. And then, as we can see, the joint model can achieve around 0.92 AUC, and then compared to image only 0.86, and clinical image only 0.8. Our senior radiologist can achieve about 0.84, while the junior fellow can only achieve 0.73. I want to highlight this interesting finding for this table here, shown here. As we mentioned, in the early stage of the disease, the CT maybe appear very normal, which means the the radiologist might just treat the image as normal. So there are 25 cases, both the radiologists, the senior and the junior fellow, mark as a normal, but actually it's a COVID positive cases. The joint model can detect 17 out of 25, and even on the imaging models or the clinical information only models can do a good job compared to the radiologist. Here's the sensitivity and specificity from compare with multiple models and then the radiologist. As we can see, the joint model can achieve almost the highest sensitivity, but for the specific part, the humans still beat the machines. Here's some examples of chest CT images of COVID-19 patients. As we can see, we can sometimes call activation maps. As we can see, the image models actually shows the activation from the images shown here. And here, this table summarizes the performance compared between AI models and human readers. As we mentioned, the joint model can achieve a similar accuracy compared to senior radiologists, better than the junior fellows and other models. And for the positive predict values, the radiology outperform the AI models. But again, for the AI models, for negative predict values, AI models outperform the senior radiologists. So in conclusion, in this work, we propose a generalized AI framework combining images and clinical data to make rapid and comprehensive diagnosis of COVID-19. And AI can achieve similar performance of the senior radiologists. In combined models has advantage to diagnose even at the early stage of COVID-19 patient with normal CTs. Of course, due to a limited sample size and clinical information in this study, further testing is required to improve the model robustness. So now I want to talk something more about our Sinai part. So as our Mount Sinai have established a Mount Sinai COVID Information Center. So actually we have a COVID-19 registry to summarize, how to put all data together from different resources like images and also the clinical information from pathology. And then this is try to create a framework or infrastructure to facilitate the researcher to perform research on that, to easily get some normalized data for further research purpose. And then I just do a quick inquiry recently about what we have right now. So as we can see here, things the early this year till now, we have over 20,000 patients with over 63,000 scans. From you can see around 20,000 positive, 37 negative, and then some under investigation cases. This is only including the chest CT and the chest array on that. And I want to also highlight some critical information here. So as we all know, the chest CT is not kind of encouraged by the CDC. That's why a lot of Sinai data, we have a chest arrays. And especially for the patient in the ICU or in hospitalization, they're almost based on the clinical the doctors. They are also do some portable chest array every 2 or 3 days, which means we'll have a tons of data for longitudinal imaging scans, like multiple scans, chest array scans from the same subject. So it will be very helpful and useful data for us to evaluate some temporal changes or temporary correlations for the disease progressions. And then compared to the previous clinical data we provided in the paper or in the research, our Sinai COVID-19 registers have even more abundant clinical information here. We have multiple flags, like whether the patient have ICU or intubation, has some the lab tests, some vitals, some diagnosis, some ECG, etc. So it will be very rich for data sets. And then our future and next step work is, because the diagnosis might not be that critical right now since the rapid test and also the abundant test. Our next phase is try to do some, prediction, like prediction the short-term, long-term outcomes. Short-term outcomes including like when the patient get the positive test or in admitted to the hospital, we need to predict them like whether the patient need to send to ICU or need to send to intubation or even discharge. The long-term outcomes that we should need to predict whether this disease will have some potential, influence on the organ levels like heart or lung, etc. It will be a long-term follow-up study for that. Finally, I want to acknowledge all of our collaborators and the co-authors for this research published in Nature Medicine earlier this year. Thank you very much.